Well, here we have listed a few relevant clinical scenarios which may affect either the perception of pain or its transmission through the spinal cord to the somatosensory cortex. Okay, here I begin with one which I have not listed. Okay, what we say, mere application of a painful stimulus is not sufficient to cause perception of pain. Okay, I explain it this way. If somebody twists my arm to a certain degree to which I'm not accustomed, I will definitely feel pain. Okay, but if we do the same with an athlete or a wrestler for whom it is quite a routine, he may not feel pain. Okay, so what we conclude is mere application of a painful stimulus is not sufficient for perception of pain. Rather, some degree of tissue damage must be there to make one feel pain. Okay, for example, if you make me work in my kitchen with fire, okay, I will feel it earlier than a person who is a cook by profession, who routinely works with fire in the kitchen. Okay, he has got a higher threshold. You got my point? So a certain degree of tissue damage must be there to make one perceive pain. Okay. Secondly, I move on to this one. Pain is not a single entity. Okay, pain has got two components: the pain itself and the emotions associated with pain. Okay, for example, if I apply a certain painful stimulus of equal severity, equal degrees to 10 people out there, their response in terms of perception of severity of pain will vary considerably. Okay, for example, if somebody slaps me on my face and I get one more on this cheek, okay, I will feel more pain with one I got from a friend. One is a person who is not known to me. I will just feel the pain. But the second one is a friend, a near and dear one. I will feel more pain because now I have emotions associated with it. Okay, so that is because of the same reason. You will see patients with old fractures, say sustained 20 years ago. Whenever they are under stress, they have reactivation of pain in that area. They seek medical advice saying, I had a fracture here. It was just okay during the previous 20 years, but now it is causing pain again. And when you go on to ask them, they are under stress due to some other reason that causes, that aids to their pain. Okay. Similarly, now we move on to the receptors, the free nerve endings. They are everywhere. Okay. So even though we don't have any such case on the record where we have a problem with the receptors, but as a whole, we have a rare disorder we call CIPA, congenital insensitivity to pain and anhidrosis. Okay, so here this is a congenital autosomal recessive condition where we have mutations in a certain gene. Most often they refer to NTRK1 gene. Okay, and at times they talk about SCN9 gene. Okay, so gene mutations in these two genes cause a rare condition where the person doesn't feel pain. Okay, I want to add, the problem is not necessarily with receptors in that condition, but they don't feel pain and temperature as well. Okay, and then again, the next scenario is that with Lissauer's tract. Okay, I don't know how to pronounce it exactly. Somebody told me it is actually a German word, a word from German language. Okay, but whatever it is, it refers to those pain fibers that enter the spinal cord but don't synapse with the second order neurons immediately. Rather, they ascend a level or two before synapsing on those lamina of the spinal cord. Okay, so what is the practical implication? For example, I want you to refresh your memory about dermatomes. Okay, so here the nipple usually lies at the level of T5 and the umbilicus is at the level of T10. Okay, so if we have a problem with pain fibers terminating in T5 or T10, okay, we have a problem with those fibers. But what we actually perceive, we feel pain a level of 2 down. Okay, a problem with nerve fibers terminating in T5 will cause pain probably at the level of T7. Similarly, problem with pain fibers from the spinal cord segment T10 may cause pain felt lower down in the pubis. Okay, so this is the significance of what we call the Lissauer tract. Okay, still later, we just discussed it earlier, the somatosensory cortex. Okay, since that is the final destination, I thought it would be the most important. Okay, but here I go on to repeat. Removal of the somatosensory cortex doesn't affect the perception of pain. Okay, and what they propose, perception of pain is primarily a function of the thalamus and those lower centers. Okay, the somatosensory cortex helps to assess the quality of pain, whether it is fast pain, dull aching pain, or some other type of pain. Okay, perception is not affected. Okay, still later, what we normally keep on telling you, fast pain transmitted through the fast type A delta fibers. Fast pain is well localized. We can localize it exactly to a certain part of our body. For example, even if my eyes are closed, I get a painful stimulus on my index finger, so I can tell you with enough certainty that it is there on the index finger. Okay, but the localization problem too has certain more elements to it. Okay, what they say, mere stimulation of the pain fibers won't allow localization. Okay, it has to, we need a simultaneous stimulation of the dorsal column medial lemniscal system to cause localization of pain. Okay, so a painful stimulus alone will not allow you to localize it that good. Okay, but if there is simultaneous stimulation of the fibers from dorsal column medial lemniscal system, those receptors responsible for light, touch, etc., we discussed in previous lecture. So that is required to allow exact localization of pain. Okay, so perhaps that should suffice at the moment. If you have any question, objection, or suggestion, please let us know in the comment section, and we will try our level best to get back to you. Thank you very much.